I didn't expect it that quick. You didn't expect it that quick? So what do you do on? Like, I know this one. Just turn it on and then I know. You press SO, the protectors. So whatever's just recording and then you well, no, they record. I just press this presentation button, so it'll show. So it'll record this. It records that and the video audience. Mm-hmm. That's okay. So, and then somebody who had used this last time. Somebody's jump drive was here. Oh, okay. That's something really cool. Huh? Okay. But now I have a slide advancer. No laser pointer, but it advances. So it should advance the slide. It's not. What do you mean it's not? See? Well, I gotta press play first. It did it yesterday. Are you serious? You see, all this happens with me. Oh, no, it's not you. It's this cruddy equipment in this old computer. Oh, that's the dongle for the. So where do I put my jump drive? I'll put this in the bag. This is the dongle for that. Yeah. So where do you put my jump drive? There's no place. No, there's place in the back for this. Okay. Just. Now, how do we know that we keep accessories for that also? For that thingy. I'm sorry. Oh, it's okay. It should be automatic wireless, right? Like the mouse. Yeah, we actually have a new mouse and keyboard I'm going to install. Wireless? Yes. Okay. So with Brian, we have a lot of technological support. There we go. Yes. It works. There you go. So yeah. The only unfortunate thing about that is as I said, there is no laser pointer, so. Oh, that's okay. That's fine. I got the mouse. Okay. The mouse is alive. Yeah, the mouse will work. So. I think we are. Okay. No. Have fun. I guess I put everybody to sleep. I should have put a video. Put a video? Yeah, you could have done it, right? That would have enlightened everybody. I should have put a middle one. It's not a video. This is not what. Well, you have to impress Dr. Naval, right? Give me the new endowed shirt. I think it'd be good shirt. Yeah, nice guy. Yeah. Impressive. See if it really works. It works, I promise. And you can even press stop. Oh, please put it on. Okay. Now you screwed me up. I believe press play because I got. Okay. Families gathering there on the farm. Okay. If you need help, I'll call you. Okay. Cool. We know how to call you. Okay. I'll see you right here. How come Dr. Harlopin, you're here so early? How come you're here so early? You don't like these patients, right? Ooh. I hear you have a birthday approaching. Oh, yeah. 200 slides. If I add Guptas, then it will be 200, right? Somebody crawling, somebody creeping. Oh. When I was a little boy, my grandmother took me to Oklahoma City one time. I was 4 or 5 years old. She had a brother worked for the newspaper in Oklahoma City. That's about all I can remember. The Daily Oklahoma. Yeah. You're here so early. Everybody all right? Gaylord. Gaylord people are still associated. Big project.
Did you grow up on a farm?
No. I'm a city boy. Big city of McAllister, 17,000 people.
Well, that name is more common than you would think 17,000. I know McAllister. What else is there? Is that you?
The prison. They had a choice. They could have a little college or a prison. So they chose the prison. And they chose Portland.
Who turned money into this?
Oh, yeah. It had a huge initial building thing on it, so the initial money on it was big. And yet the long-term effect was not as positive. Not as positive.
I can't remember, you may well have been the one that told me that the reason University of Texas at Galveston Medical School has done so much better than I would, at least than I would have thought that they could by their size.
You can sleep.
I didn't tell you that, but that's
The title.
they have a big
It's gonna be interesting.
prison population.
I'll pay attention.
It's okay. Oh, I can hardly pay attention when I'm on service. It's just impossible.
Oh, I couldn't wake up this morning.
I don't blame you.
My ass.
What time? Yeah, I don't blame you. I mean, it's just impossible to be honest.
It's an admission
Can't wait.
at 2 a.m. Well, not in the evening. Like, it was an admission that woke me up. So I could still. Hash woke me up. Last night. I had to keep him in.
Did you
No. So like it was from Monday. Still got CT scans, still workouts, you know. Anyways, we have to admit them anyways, you know, and with the mom, Karen, Hemorrhage was back up. You're gonna talk with him today? You already talked
Yeah,
with him?
today.
Today.
You spoke to him.
Yeah, nice guy.
We'll talk later.
Yes. It's gonna be interesting to get him in. It's going to be interesting. I don't know if he's going to be a candidate for a seat chair though. I don't think that he will really get the chair. I don't know, I think that the target was somebody more senior than that. I don't know.
That is not a...
I don't care. He could be
That is not a thing. He had so many years of experience. Oh, yeah, 2007 onwards he shut down.
Well, yeah, he was before that on.
So 2007, it's not the thing, right? He's been an attending for He's not...
So,
That's fine. It's too early to know. Too early to know. No, you need to have some money there. I mean, he's not too premature. You know what I mean? He's been out for more than 5 years. 5 years as a seasoned person. To be honest.
well, you're a senior, right? How many years have you been on?
Oh, 1 year.
1 year old? A little more senior than us.
No.
But in a great place. Great mentors, great people, everybody keeping him up to the latest. I think it's not a bad choice.
Let's
Senior person, then that one is going to be one. More free time, right? More protected. Rather than what he's going to do program. So, bringing him in as a second look for a senior person. You know, like Joe Cahill, for example. Or just have all these guys for 10, 15 years or 20 years.
it all depends on who's willing to come. Too early to say. Too early.
Well, I just don't have these people interested in this country.
Even the whole thing is, you want to change in the weather.
Yeah. Yeah, well, temperature is low and
See something else. No, some people will say, I just want to change,
They just keep going.
Complex and long, lots of radiation and all that.
He told me that they accepted
Well, we have seen some a friend of mine.
It was very everything. I have two 7, 8 or 7 in
So let's start. I guess it would be of lesser expectation than Dr. Gupta's, who had a lot of moment disorder videos. I should have stolen in one video and put in the middle. So it's going to be a dry topic, but it was done at some request of some of the residents who really wanted this topic. So I'm just going to talk about when it's not intracerebral hemorrhage. Well, you can see what the topic leads to. So, well, I'm just starting the rounds with a case. So we have a 46-year-old lady with no significant past medical history. She had sudden onset of headache at her work and she got collapsed. EMS was called, they intubated her in the scene and she was brought to the ED. Very common scenario, right? So on your physical examination, as you notice, she is not following commands. She is opening her eyes to noxious stimuli. She has her left gaze preference. She opens, her left pupil is dilated and is not reacting. She moves the left side spontaneously and she withdraws the right side. Well, after the triage, this is the CAT scan what we obtained. As you see, there's blood within the within the parenchyma, as well as IVH, along with some subarachnoid blood. And on the CTA, she had a terminal IC aneurysm, for which she underwent a clipping. And so the topic what I'm going to talk is about aneurysmal subarachnoid hemorrhage, which is a subset of intracerebral hemorrhage. So what I'm going to then accomplish, briefly would be the epidemiology, the rebleeding, vasospasm, seizures, hydrocephalus, the prognosis, and the long-term outcome. So the brief epidemiology, it constitutes about 3% of all the strokes, 9 cases per 100,000 person years. The mean age is 55, so it's lesser when compared to the other kinds of strokes. Bit higher in women compared to men. It's usually not congenital, but usually develops throughout the entire life. Various risk factors associated as formation and enlargement would be hypertension and smoking. If you have hypertension and smoking, the odds of it, it has a very additive effect. If you have had one aneurysm in the past, if there's a family history of intracranial aneurysm and various genetic conditions. But strangely, hyperlipidemia, hypercholesterolemia, and regular physical exercise reduces the risk of aneurysmal subarachnoid hemorrhage. What are the clinical features? If you have a ruptured subarachnoid hemorrhage, worst headache of the life has been reported in 80%, sentinel bleed in about 10 to 40%. It increases the risk of early rebleeding by 10-fold. Immediate death before medical attention has been seen in 12%. You may have nausea, vomiting, stiff neck, photophobia, loss of consciousness, seizures, focal deficits, coma. Also, about 4 to 16% of out-of-hospital cardiac arrests are basically subarachnoid patients. These are predominantly women. They have a history of headache. They have a sudden onset headache. They lack other comorbid conditions.
Usually asystole, and the PA is the first initial rhythm. So when you, this was on autopsy as well as retrospective analysis. And for unruptured subarachnoid hemorrhages, they are usually asymptomatic. Symptoms can be there from just the mass effect, cranial nerve palsies, as well as brainstem compression. Usually your initial test of choice when the person comes to the ER would be your CAT scan. And if it's non-diagnostic, the patient needs a lumbar puncture. So the different grading scores then over here which have been used would be the Hunt and Hess. And one being the asymptomatic to deep, then the fifth one being deep coma. And the Fisher, you had a modified Fisher. I guess, you all can always open online and then see what the scoring is, adapt a single method, and then continue with it. As well as then we had the World Federation Neurological Sciences classification. So now, you have to know the severity of it because it would help you determine the long-term prognosis of it.
So what's the difference between thin and thick?
Thin would be less than 1 millimeter, and then more than 1 millimeter slice. So that would be the thing. And rebleeding. So the rates of rebleeding which have been reported in literature is about 4 to 13% in 24 hours and about 3% in 72 hours. It all depends upon your cutoff. Usually occurs within the first few hours. So initially you get a call from the outside hospital, the patient is better, but when the patient arrives to your hospital, the patient is worse. So you suspect rebleeding is a great thing which has happened. It peaks at 2 hours. So it's a major risk factor of early neurological deterioration. The mortality from rebleeding has been seen in 20 to 60%. So this was a comparison of why did the patients rebleed before the patient came to the hospital. So they took an analysis of the blood pressure recordings before the patient rebled, and then did an outcome analysis. So they noticed that with increase in the blood pressure, there was an increased rate of rebleeding, especially you see at systolic blood pressure less than 160 was significantly different. So with each elevation of the blood pressure, the odds ratio of rebleeding increased significantly. So that's why blood pressure control is really a key important feature before the aneurysm is fixed. So what are the risk factors of rebleeding? Age, again, a little bit higher age, it was about 55. So the more higher the age, the increased risk of rebleeding is higher. If the size of aneurysm is more than 10 millimeters, if the systolic blood pressure is more than 160, or if they have a higher Hunt and Hess grade, that is grade 4 and 5, or if they had posterior circulation aneurysms, if they had an intracerebral hemorrhage and an IVH, substance abuse, and higher glucose. So these are the risk factors that are prone to rebleeding. And what would happen if you have a rebleeding to the course and incidence of vasospasm in these patients? There's a higher chance that these patients can become hyponatremic. They can have respiratory failure, hydrocephalus, they develop fever, higher mortality at discharge as well as at 1 year, a higher incidence of brain death, poor outcomes at discharge, and increased risk of IVH, ICH, as well as subdural hematoma. But there was no change in incidence or timing of delayed cerebral ischemia in these patients. So currently, the AHA recommends that a reduction of blood pressure, especially before the aneurysm is secured, is a key important feature in these patients. They recommend at least a reduction of systolic blood pressure of less than 160. If you have an ICP monitor, then you need to target it to a CPP. That would be more ideal. So what about short-term antifibrinolytic therapies which have been used in these patients? So initially they use all these agents, for a longer period of time. They use it at least for about 7 days. So it did reduce the risk of rebleeding to about 1%. It was not zero, but there was a higher incidence of delayed cerebral ischemia. So that was the earlier studies. So because of higher incidence of delayed cerebral ischemia, the usage became much more lesser. But then, again, some analysis, showed that if you would use it for 72 hours, it did not increase the risk of delayed cerebral ischemia. So if you cannot then transfer the patient or you cannot do the immediate surgery, you can use it for about 3 days. So then coming to the major important feared complication would be vasospasm. So it's a very huge topic, and I've just dealt with the brief important points. Well, it has a very complex mechanism than just simple constriction of the vessels. For med students, it's just constriction of the major intracranial vessels. There's a whole different pathophysiology to it. And there are different terminologies which have been associated with it. Angiographic vasospasm is, that is, you would have narrowing of the blood vessels when you do an angiogram, and it should not be because of atherosclerosis or because of catheter spasm or because of vessel hypoplasia. TCD vasospasm is when there's elevation of the mean flow velocities for that particular circulation. Now you can find angiographic vasospasm, in 70% of the patients, but only about 30% become symptomatic. That is, they have neurological symptoms because of the vasospasm. And usually vasospasm is seen after a few days down to about 2 weeks. Sometimes even, it can be even more longer. Symptomatic vasospasm, which has the term has been coined, when there's development of focal neurological symptoms or decline in level of consciousness or both because of ischemia, there's lack of blood flow to the brain. You need to exclude out causes like hydrocephalus, seizures, metabolic derangements, infection, and sedation. Cerebral infarction, that is vasospasm related new cerebral infarcts, when you see new hypodensities on CAT scan because of vasospasm, again you need to rule out, exclude out other possible etiologies. Delayed ischemic neurological deficits, these have been coined. When you have symptomatic vasospasm, it can be global or focal, or the signs and symptoms of new cerebral infarction on imaging. And both TCD as well as angiographic vasospasm has not been correlated with any aspect of clinical outcome, but symptomatic vasospasm as well as delayed cerebral ischemia, that is if the patient has symptoms or if the CAT scan is showing hypodensity, it has shown to be correlated with reduced activities of daily living, cognitive impairment, and poor quality of life. But only delayed cerebral ischemia was associated with severe death and disability at 3 months. Now, what are the risk factors of vasospasm? Younger the age, smoking, hypertension. If there's a high-grade subarachnoid hemorrhage, again, if there's large amount of blood, diffuse subarachnoid hemorrhage, clot, thick cisterna clot. If there's IVH or if there's a delay in the treatment, there's an increased risk of vasospasm. So this was just like a small study to just estimate the risk when the person comes. So it was based upon the age, the clinical condition, based upon the modified fissure, and the amount of subarachnoid blood. So if you were then elderly and if you have thick subarachnoid blood, your chance of developing vasospasm is about 54%. But if you're younger than 55, you see it went up to 61. So it just gives you the probability. Less than 20 is low risk, 20 to 40 is average risk, and more than 40 is high risk. So it just tells you, various predictors and a simplistic tool which you may use it at bedside. So coming to the major trials which have been used. So the initial trial was the one in 1983, the original Nimodipine trial. So it was a controlled trial where 125 patients were enrolled. It was a multi-institution, prospective double-blind, placebo-controlled trial. So in patients who presented with subarachnoid hemorrhage within 96 hours, and it was used for about 21 days. So they measured the deficits because of spasm that was persistent, or it was severe, or death because of 21 days. So that is the consequences of vasospasm were measured. So it was higher in the placebo group when compared to the Nimodipine group, and this was significant. Now, subsequently, multiple other randomized controlled trials have been performed. All of them have demonstrated there's a reduced incidence of vasospasm-associated infarctions and poor outcome following it. So that's why it has been a tradition to use Nimodipine. Now, since Nimodipine now has been available IV, so now what is the comparison of then a PO versus IV? Again, this was then a small trial. So they compared oral versus IV. There was no difference in incidence of delayed ischemic neurological deficits or ischemic lesions on the CT, clinical outcome, or the quality of life between both the routes. So now, we all love statins. So then what is the data on statin? So the initial pilot trial, they compared the use of simvastatin versus placebo. It was given within 48 hours of patients with aneurysmal subarachnoid hemorrhage. What they measured was symptomatic vasospasm, that is clinical symptoms with your radiological test. And all they noticed was the Doppler velocities were significantly low in the statin group. Also, vasospasm was significantly lower in patients who received statin. So this was the initial trial which led to further more data. So now this was just a recent multicenter trial which has just come out. And so it was a multicenter trial done at 35 centers. Again, it was a double-blind trial. Patients who presented within 96 hours were randomly allocated on 1:1 basis. They measured the modified Rankin score at 6 months. Favorable outcome was MRS of 0 to 6. So they enroll about 803 patients, were randomly assigned to either the simvastatin group or the placebo group for at least 3 weeks, and the outcome was measured. So what did they measure was a favorable outcome. It was no difference, as you see, the curves at 6 months as well as at discharge. No difference in the outcome. Even the mortality was similar, so there was no benefit with use of statin on both short-term as well as long-term outcomes.
Okay.
Yes, sir.
I'm curious, did they have some scientific basis for investigating this, or was this just a fishing expedition?
No, I think they had scientific things. So this was the preliminary data. This was in 2005, as well as even so many animal studies, endothelial stabilizers and everything else. So they had a lot more data. But many other things were very contradicting. Few things showed. The one from Cleveland, it did not show. So, so many other things were retrospective. So this was a more prospective thing. Oh, yeah.
But that statin's added after hemorrhage,
Yes,
not prior.
yes, not prior. I'll come to that slide also. Yeah. So statin.
Do you know why they picked the lower dose?
No, I did not go through that.
40 is not that low. 40 in the study is not that low.
I know in the samples they use 80, but
Well,
I know, but our patients. No, I don't know. I'm sorry. There was no time to look into. Yes.
So there is an ongoing trial looking at 40 versus 80 of simvastatin,
Okay.
which started after this one had already started.
Okay.
Perhaps I will show something. But again, just to your question, they had found a correlation of patients that came in on statins with subarachnoid hemorrhage having significantly lower rates of vasospasm coming in.
See, this is
So
a one.
that's
Yeah.
another reason they were.
Yeah.
What was the size of their supplement statin?
So this, yeah. I'm sorry, it's a lot of data. So this was your question, what about pre-admission statin use and functional outcome? So again, this was data on 295 patients. All the patients were treated, who were treated, got statin when they got admitted. But they looked at, patients who got prior statin use. It was about 50 patients in this group. There was no significant reduction in favorable outcome. But and there was no significant difference in delayed cerebral ischemia. So prior statin use. But again, you're having a very small subgroup, about 50 patients out of this 300.
There was a lot of people from MGH that seemed to contradict this for some reason.
Okay.
And they actually said if you stop the statins when you come in, you have a rebound increase in the rates of vasospasm. But people have been going back and forth about this for years.
That's with everything. Right? Either you like it, don't like it. I used to see a lot of elevation LFTs, most of the times you just can't, they would go higher and higher. So many of us love albumin. So what was the data on albumin in patients with subarachnoid hemorrhage? Again, this was a small, retrospective analysis. So patients, after they secured the aneurysm, they got normal saline bolus. If they failed to achieve a CVP of more than 8, then they received albumin. The second group only was resuscitated with normal saline. Now they compared the patients who got albumin versus non-albumin. Again, it's a very small group, So patients who did not receive albumin, they were there was a difference in the age. They were mainly men. They had a history of hypertension. They were more likely to have hypomagnesemia, more likely to have hydrocephalus. But symptomatic vasospasm was not different, but again, it's a very small thing. But they were more likely to have good outcome in patients who got the albumin group, And then again, so this is the other trial, which was again a safety trial. It was a dose escalation trial, phase 2 trial. So they then I checked the dose of albumin. So escalating doses of albumin was given for then here 7 days. What they measured was they analyzed if the heart failure anaphylaxis functional outcome at 3 months, So this was analyzed. And what they noticed was daily albumin levels, definitely there was an increase in all the subgroups. But the group who got 1.25 grams per kilogram, the functional outcome was more better. It was good outcome and this was poor outcome. The blood pressure was highest in this group when compared to the other trials. And the group which got the largest most dose of albumin, they did worse overall. Well, so at least they knew that with the tolerance, 1.25 grams per kilogram was safe enough. And then the phase 3 trial is right now undergoing. We have to see what the results show. And so what about the magnesium? Everybody loves magnesium. So it blocks the voltage-gated calcium channel. It decreases the glutamate release and entry of calcium, so it causes vasodilation. In the animal data, it definitely reversed, the delayed vasospasm after subarachnoid hemorrhage. And in a matched cohort analysis where they analyzed 38 patients with continuous magnesium sulfate infusion, it was given for about 12 days. And symptomatic vasospasm was significantly low in patients who got magnesium sulfate. So, but like there was no improved outcome or Glasgow outcome score from magnesium sulfate. So this was just the preliminary data. So then like what about prophylactic magnesium sulfate infusion? So again, this was a randomized, it was a placebo-controlled clinical study. So again, they had 110 patients. They got a magnesium sulfate bolus followed by an infusion. And then the control only got saline for about 10 days or until the vasospasm was resolved. So they targeted the magnesium levels to be just normal, 2 to 2.5. What they saw was the delayed ischemic infarction was definitely lower in the magnesium sulfate group. The vasospasm was lower in the magnesium sulfate group, but the good outcome and delayed ischemic neurological deficits, that is, the consequences from the vasospasm was not significantly low. So it can reduce it, but then the overall outcome was not different. So based upon this, there were multiple other pilot trials, larger trials. So it was the IMASH trial. Again, it was a phase 3 trial, double-blind placebo-controlled trial. They enrolled 300 patients, around 327 patients, about half and half in the magnesium sulfate and the saline group. Magnesium was given for about 10 days. Favorable outcome was similar in both the groups, as you see. And there was the secondary outcome, what they measured was the modified Rankin-Barthal index, as well as even the mental function with a short form scale. And the clinical vasospasm, there was no significant difference. So this was a smaller trial. There was a bigger trial, which was the MASH2 trial, where they enrolled 1,204 patients. Again, like, half and half was in the magnesium sulfate versus the placebo. There was no significant difference in poor outcome. Now, poor outcome was MRS 4 to 5 at 3 months. So again, this was a larger trial which showed magnesium did not help. And in a large meta-analysis of 2,000 patients, magnesium sulfate was not superior to placebo. What about other medications which have been used? Clazosentan, it was like an endothelial receptor antagonist, and it inhibits the endothelium-mediated vasospasm. Again, in the phase 2 trial, there is a conscious one study. There was a dose-dependent reduction in angiographic vasospasm. So they studied 3 doses, 1 milligram, 5 milligrams, and 15 milligrams per hour. And then, they saw, there was a dose-dependent reduction in angiographic vasospasm. So based upon the prelim data, again, the conscious 2 trial, which was a phase 3 trial, was done. Patients who underwent clipping, they were randomized to the drug versus the placebo. And what did they notice was looked at the primary outcome at 6 months, this was the all-cause mortality of vasospasm-related infarction, delayed ischemic neurological deficits, and rescue treatment. It was not different in all the groups. I'm sorry, there's no point. And this was each thing broken down. Depth was similar, new cerebral infarcts were similar, delayed ischemic neurological symptoms were similar, and the rescue therapy, they were all similar. There was not major difference. Secondary outcome, that is a Glasgow outcome score, less than 4. Again, that was not then as significant. So the conscious 3 trial, that is the patients who had undergone coiling, it was prematurely stopped based upon this data. It did not help in patients who underwent surgical treatment. So it was stopped prematurely. So what about the other agents? Cilostazol, again, this is it's a phosphodiesterase inhibitor, and it has its antiplatelet as well as vasodilatory properties, and so that's why it was used. So in this trial, they had anti-recirculation aneurysms. They were given the medication, 100 milligrams twice a day, versus the placebo. It was given within 96 hours, and again, about 114 patients, half and half. They were divided. The incidence of angiographic vasospasm was significantly lower in the cilostazol group, and new cerebral infarction was low, but in this group. But the clinical outcome was not statistically different.
Does it cause priapism?
I did not look into the data. Okay. So, effect of cilostazol in patients with subarachnoid hemorrhage. Again, this was a large meta-analysis. So that was they included 2 randomized control trials and 2 quasi-randomized control trials. So 340 patients were used. And the incidence of symptomatic vasospasm was definitely lower. The number needed to treat was about 6. Severe vasospasm was definitely lower. The vasospasm related cerebral infarctions was definitely lower. Poor outcome was also lower. So all the things were significantly low in the patients who got the drug, but the mortality was similar. So this was again, so it favors the cilostazol group. That is, if they had symptomatic vasospasm, severe vasospasm, if they had new infarctions, or and poor outcome. So everything favored the group. Again, this is a meta-analysis. We have to look into this more bigger trials. What about the new things? They are using a low dose of IV heparin in patients with aneurysmal subarachnoid hemorrhage. So again, like, this is a retrospective analysis. They had 86 patients of a Fisher grade 3, and it presented within 36 hours. They underwent clipping, within 48 hours. So after the 12 hours after the surgery, usually they started low dose of heparin. It was started at 8 units per hour, gradually increased within 36 hours to 10 units per kilogram per hour. So what did they know? They continued it till day 14 after the insult, and they had an equal amount of control group. What did they notice is, the angiographic, the vasospasm was similar, but clinical vasospasm was lower in the heparin group, as well as CT infarcts was low in the heparin group. And anyhow, it was just very underpowered to see the discharge disposition, which was almost equal. So now larger trials will be.
You had a target PGT or something?
No, I think no target.
Just a standard
I think,
unit per hour, and that's it?
Yeah, I'll send you that later. Yeah. Because it has just that anti-inflammatory properties and blah blah blah, so that's how. Yeah. I mean, it was a surgeon who's doing it, so. There was no increased risk of bleeding, so that's great.
That's good.
Yeah.
Be careful, Dr. Greenfield's father was a surgeon.
That's okay. That's fine. Maybe next birth I'll be. Okay.
Coiling instead of clipping.
Huh?
Do you have any with coiling instead of clipping?
Okay. Tirilazar. Again, this is it's a non-glucocorticoid, but it's a free radical scavenger. So in a large meta-analysis of around 3,000 patients, there was a reduction in significant vasospasm, but again, it did not then cater to functional outcomes. So the Glasgow outcome score, it was not clinically significant. Now, how about coming to the next management, which has been out as well. We all know the Triple H therapy, and how did this come out? So the initial reports were in the 1970s, I guess. So where they noticed when you elevate the blood pressure, patients with neurological deficits, after the subarachnoid hemorrhage, they improved. And so the initial things was like elevation of blood pressure, then they had volume resuscitation. They noticed, small studies. 1983 was the first, the preliminary report where they compared, they had two groups, where one in which they induce a hypertension and volume expansion versus the control. There was a decrease in incidence of vasospasm in the treatment group. So this was the prelim report. And later, larger series of about 40 out of 60 patients, definitely they had improvement. So this was just the prelim data where this comes out. Now, based upon this, there were multiple other trials as well as a large meta-analysis. They noticed that there was a reduction in symptomatic vasospasm, but not delayed ischemic neurological deficits. But still, the main trend is to just keep them euvolemic. You don't want hypervolemia because then you'll flood the lungs, you'll have pulmonary edema, a lot of consequences, but you do want to keep them hypovolemic. And induced hypertension, definitely it increases cerebral blood flow because the autoregulation is gone. So induced hypertension, yes. So there's no role for prophylactic hypervolemia and Triple H therapy. And induced hypertension does not increase the risk of rupture of unsecured aneurysm. So many of the patients, with the rupture, they have ruptured as well as unruptured aneurysms. So if they have an unruptured aneurysm which has not been secured, there's no increased risk of hemorrhage. What about the data which is coming from the various pressors? So cardiac enhancement from dobutamine in patients refractory to hypovolemic therapy. So again, this was, they had around 200 patients. So these patients had prophylactic hypovolemic, that is, they maintained them with fluids, they got albumin, they got ringer lactate. In spite of all this prophylactic thing, about 30% had neurological compromise from vasospasm. So in these patients, dobutamine was given. And so the target was to keep the cardiac output and the cardiac index above the physiological level. And they looked at the clinical response. They continued it, until the patient had improved and tapered it gradually over a few days. Out of these 55, 22 patients responded just with more hypervolemia. That is, they gave the more amount of fluids, more albumin. They maintained the wedge pressure 12 to 16. Out of these remaining 23, just with the dobutamine alone, 78% had clinical reversal. So that's why this came, dobutamine started being used in fashion. So all these patients, when they put us on gangs, all the cardiac index and the cardiac outputs were normal. So all they had to do is raise it above the physiological level. So just by increasing the cardiac output, it increases the microcirculatory flow without changes in the MAC or the velocity or the blood viscosity. So what about its prevention? So dobutamine in a single center trial, again patients with moderate to severe vasospasm, they were randomized to either dobutamine and norepinephrine. Now they compare these two pressors, whether does it prevent vasospasm. It's just a very small pilot trial. 17 patients in the dobutamine group and 18 patients in the norepinephrine group. There was no difference in the development. So this was prophylactic, so no difference in the development of angiographic vasospasm. No difference in the development of delayed ischemic neurological deficits. So again, you don't want to prophylactically use pressors. It does not prevent the formation of vasospasm.
There was a placebo arm also?
No, but this is, no, there's no placebo arm. But there was another paper.
Basically, maybe they both have the same effect.
And that another paper, yeah, I don't know. No, too much.
Okay.
Yeah, I'm sorry. No. So, Milrinone for treatment for cerebral vasospasm. So we all love Milrinone. It's an ionodilator. So it just increases your cardiac output plus it vasodilates. So again, it was a small pilot study. Again, they had 22 patients with angiographic vasospasm. That is, they were treated with intra-arterial Milrinone followed by infusion of Milrinone. It was continued for about 14 days. And they look for if there was angiographic vasospasm, if their hemodynamics could be tolerated, neurological outcomes. So they had 34 arteries, which were 34 intraarterial infusions were done. And what happened is there was a 50% increase in the arterial diameter. So definitely the arterial diameters, it caused dilation. And in 5% of them, that is 23 patients, there was recurrence. Then they still required further intraarterial therapy, and 3 of them required angioplasty. 2 patients died and 2 patients lost a follow-up. So out of the initial 22 patients, so they had data on 18 patients. From those 18 patients, what they noticed the MRS at 1 year, definitely it was pretty good, it was 0.8 to 1. The Barthal index was around 100. So this was just again a pilot study. About 40% risk went back to the activities of daily living, including the professional life. The rest 9 had mild disability, which as well as which involved his memory and the sleep. So this was a small pilot trial. So based upon this, the Montreal group adapted this protocol. So whenever the patient had a clinical evidence of vasospasm, of course you need to rule out other causes, and then you start Milrinone. You volume resuscitate them, maintain a CVP of more than 6, correct all the possible factors, start Milrinone, and if the blood pressure is low, you start norepinephrine to keep the MAP, decent MAP. If there was no improvement, you would increase the Milrinone, start norepinephrine to keep a MAP of more than 90. If there was no improvement within 30 minutes, again they would take for an angiogram and repeat Milrinone bolus after that, subsequent angioplasty. So these, they had enrolled 88 patients with vasospasm. They had a follow-up period for about 44 months. The mean age was about 50. The duration of where the user treatments were about 9 days. There was no significant side effects, and the mortality, 5 patients, with this severe vasospasm died. Most of them because of delayed cerebral ischemia, there was brain herniation.
Were they treated with Nimodipine too?
Yeah, I think that they did not mention. Yeah, I think, they all got. That's a part of the protocol, but this is just Milrinone was not using. What they noticed was nearly 48% returned back to the previous baseline. So, this is at 1 month and this is at 12 months. So good functional outcome at 1 year in the 75% group. So Milrinone, was pretty much quite adapted over there. And comparison between dobutamine and Milrinone. Both of them are ionodilators. Dobutamine has more beta-1 activity. So again, this was just a small pilot study. It was, I think, retrospective analysis of 11 patients who had a PA catheter. So what happens is Milrinone, it is more potent than dobutamine, increasing the cardiac output, the stroke volume, decreasing the SVR and the systolic blood pressure when compared to dobutamine. So it is more effective when you have a reduced systolic function. but you need to have a good peripheral resistance because it will drop your blood pressure. Dobutamine would be good if you have a low SVR and a low blood pressure. So you have to cater your patients based upon how their hemodynamics are. So market reduction. So what about the other techniques which have been used in literature? Lumbar drain. We used to use lumbar drain before. Again, this was a non-randomized trial. They used, with the basic concept was to just remove the blood out, because blood was an irritant. So hopefully you clear the CSF and reduce the incidence of vasospasm. So definitely it reduces, in this pilot trial, it was retrospective. It reduces the incidence of clinical vasospasm, the need for angioplasty and vasospastic infarction. But they were more likely to be discharged home, and the Glasgow outcome score was also better in patients who got a lumbar drain. And then, so based upon this, a larger trial, the LUMAS trial, it was a single center prospective trial. Again, they used in high-grade subarachnoid hemorrhages. They had equal cases and controls. They looked at the modified Rankin score. But of course, the investigators, seeing the outcome at 6 months, did not know whether the patient got the intervention or not. So in that way, it was blinded. And delayed ischemic neurological deficits was definitely much more than lower. But the modified Rankin scale, at 10 days there was a definite difference, but at 6 months did not make a difference. So again, well, it may improve immediately, but long term, it does not improve a whole lot. So I think, it's just not worth it. And then therapeutic modalities, what are the different things that you can use? Well, once a patient fails the triple H therapy, definitely they go to the angio. So what is the data on angiogram? So and how fast it should be done. So again, this was a retrospective analysis on about 466 patients. 93 patients underwent endovascular treatment. If they failed medical therapy, that is triple H therapy, was maximized to a MAP of 130, 140. So patients who failed, went into the angio suite. So they had about 51 patients who got treated within 2 hours, and then 33 who got treated more than 2 hours of neurological decline. So they compared both the group. Patients who were treated within 2 hours, they had significant clinical outcome when compared to patients who were resuscitated later. So this is where the early cutoff window of things comes from. And then again, based upon this, further future studies have come. They had, this was on the Columbia group, of about 600 patients. They had around 95 patients develop symptomatic vasospasm. With volume resuscitation on 94%, 43% responded. And with vasopressors, again, 70% responded. Angioplasty was performed in 30%, out of which 80% had clinical response. So what they did was, patients who got volume expansion or pressors within 2 hours, patients who clinically responded within 2 hours were compared to the non-responders. Those who had early clinical response were less likely to die or become more disabled than those who did not. But still, clinical response was not correlated with the functional cognitive outcome. It did not translate. Coming to the next common things which we always get consulted on is seizures. And so onset seizures, different data, different frequencies. You see, it is seen in 4 to 26%. It can be early seizures is usually hypothesized because of herniation or race ICP. And early seizures that is during hospitalization can be seen in 5 to 10%. The risk factors would be either you have an MCA aneurysm, if you have a large amount of subarachnoid blood, intracerebral hemorrhage, that's rebleeding, infarction. If you have a poor grade, once again, it's the same thing. And subdural hematoma, hypertension, and hydrocephalus. Delayed seizures after discharge can be seen in about 4 to 8%. Late epilepsy that is beyond 2 weeks was about 5%. Again, the risk factors of late epilepsy would be if you have a poor grade subarachnoid, if that Glasgow outcome score at discharge was poor, and if they had severe postoperative deficit, which was persistent, if they had loss of consciousness for about 1 hour at the time of onset. Perioperative seizure was not a predictor of epilepsy. So in a large meta-analysis of around 7,000 patients, early postoperative seizures were seen in about 2%. Late postoperative seizures were seen in 5%. Late postoperative seizures, you can even see it 7 months down the line. So, the predictors would be if the person has had an MCA aneurysm, again, a large amount of subarachnoid blood, or they have undergone clipping. So, because of the scar tissue. And what is the aSAH data? Everybody knows it's it had around 2,000 patients. 14 patients had seizures prior to presentation to the hospital. So 10% had seizures after randomization. And people who had endovascular treatment, it was around 8%. and in the neurosurgical group it was 13%. So definitely there was a significant difference, especially the patient who underwent clipping. In 19 patients, it was the seizure was just because of re-hemorrhage. Seizures after discharge. They saw the seizures at 1 year and 5 years. At 1 year in the endovascular treatment, it was around 3%. At 5 years, it was 6%. So again, it was higher. So again, in the neurosurgical group, it was 5% and 9%. As you see, the curves are going up higher. So even up to 8 years, there was increased incidence of seizures. But after 8 years, the cutoff, it had plateaued. More higher in the neurosurgical group when compared to the endovascular group. So again, the risk factors were if they had clipping, younger age, and then large amount of subarachnoid blood, if they had delayed ischemic neurological deficits from vasospasm, thromboembolic complications, if they had an MCA aneurysm. And definitely, so again, I mentioned it plateaued at 8 years. What about if they were elderly? That is, elderly, they took the cutoff of 65 years. And there was a great difference, in the neurosurgical treatment group, it was around 30% when compared to the endovascular treatment group, it was 1%. Well, many of the patients, they described tonic-clonic activity at the subarachnoid than onset. So that is, it may be it may be focal or it may be generalized tonic stiffening or posturing. You may have even myoclonic jerks of the extremities. And usually this occurs within 6 hours of the onset of bleeding. Now, would you call it a seizure or what? We don't know. So it is seen in 3 to 21%. Again, in a prospective study, it was seen in 11%. The patients who had this tonic-clonic activity, they were mainly younger. They have poorer clinical grades. They had large amount of blood. There was definitely an increased incidence of in-hospital seizures, pneumonia, delayed cerebral ischemia. But it did not translate to poor outcome, mortality, or epilepsy. So what about incidence of seizures again after clipping and coiling? Various contradicting data are there, but this was a large meta-analysis. I think, so they had ruptured aneurysm. This is from the national inpatient sample. Ruptured aneurysms, they had 10,000 patients. Unruptured, again, around 9,000 patients. In ruptured aneurysm, there was similar incidence of seizure or epilepsy following clipping and coiling. Whereas in the unruptured, there was a higher incidence of seizure or epilepsy when they had a clipping compared to coiling. So definitely, when the patients are epileptic, definitely increases your hospitalization, increases your charges, but except if they are unruptured, and a coil group. So what is the data? How much of what dilantin which comes from? So this was again a retrospective study. So they saw the dilantin burden. What they saw is the amount of dilantin levels times the number of days, how the patients can be affected just because of the amount of dilantin. So they took what is called the phenytoin burden, and it was associated with poor outcome. As you said, the higher the level of the phenytoin, the more poorer the outcome. So that's why, we need to be careful when we give all these medications. So higher phenytoin burden, higher poor cognitive outcome at discharge as well as even at 3 months. So there was a poor functional outcome at 14 days. For functional outcome, it was not difference, but definitely cognitive outcome, there was a difference. So we are using nowadays.
Does that correlate with levels at all?
Yes. So what they took was the average phenytoin level times the number of days. Okay. They took it for 14 days. Usually you give it, patients are here for 14 days, right? So cognition is definitely affected, but the functional outcome is not much affected. But cognition is very important, right? When you learn. So what about since we are all trending to the levetiracetam. So again, this came from the WashU. So around 400 patients with subarachnoid hemorrhage were analyzed. So the dilantin patients, they got a load and they got a maintenance. Now with the levetiracetam group, they got they did not get a load. They just got 500 milligrams BID for 3 days. That's it. They stopped it. They looked into how many patients had early seizures. And that is before 3 days, it was not different between both the groups. Late seizures was more in the levetiracetam group, Well, part of the thing as well, they did not get a load, so many things. So the levels may not have been enough therapeutic, or maybe 500 is too less, So this could be some argumentatives.
Did they load them with levetiracetam?
No, they did not. That's what they are saying, no, that they did not load them, So the levels may not.
Days.
Yeah, just fine. Yeah, they stopped it at 3 days. And dilantin, they continued the dilantin.
Oh.
So that's what, But you see, the median duration for seizure occurrence, in the phenytoin group was 4.5, in the levetiracetam group was 4. And then no seizures occur after 8 days in the levetiracetam group and after 11 days in the phenytoin group, Poor outcome, again, it was similar between the both, So like, well, whatever drug you choose, you have to think, what.
So, Archana, there wasn't a randomized trial, though, right?
No.
So what you used to have a policy to do a week of Dilantin, and then they changed to 3 days of Keppra.
So it was comparing old versus
new. And that's why they had to correct both for the days, the duration of therapy, and for the change of drug, which is a little complex.
You're right, you can't compare, because it's not prospective. You're right. I mean, like, I would give a load, because if I have to use this drug.
Oh, use it for 7 days.
Huh?
Use the Keppra for 7 days.
Yeah, that's right. You're right. So what about AED prophylaxis in prevention of early and late seizures? Again, this is a retrospective study. It's a very small study, but like, it's very hard to, compare things because, one person uses early seizures, one person, the cutoff limits are so different. Retrospective review of 260 patients. The timing of AED prophylaxis had no effect on incidence of early and late seizures. AED use was associated with increase than a rate of early seizures. So patients who had prophylaxis, in fact, had more early seizures. But late seizures, there was no difference, So again, this was the rupture group. Early seizures who got prophylaxis was this dark one. Any kind of prophylaxis, was the gray one is who did not have prophylaxis. In fact, early seizures will happen whether you give the drug or no. But then like late seizures, there was no significant differences whether you got your prophylaxis or no. Again, what is the data? Where is the data coming from? 3 days of Dilantin prophylaxis is enough or no? Again, it was a retrospective study. So the first 9 months, they analyzed, patients they continued Dilantin until the patient got discharged or if they developed a drug reaction. And the last few months, they took, where they gave Dilantin only for 3 days. And then they followed up these patients for about a year. There was no significant reduction. So there was a significant reduction in complications because, well, in the non-Dilantin group. But there was no difference in seizure rate in hospitalization on follow-up. So that's why they said, 3 days is more than enough in these groups, because it does not reduce. There was no difference in patients who got for less than 3 days, for 3 days or more than 3 days. So that's why short-term, Dilantin is more than enough. Then how was the outcome of patients treated with antiepileptic drugs? Again, there was it was data from 4 randomized double-blind trial. Again, antiepileptic drugs were used in about 65%. Usually, the most predominant factor was the physician was administering the drug, whether they wanted it or no. And predictors of administering the drug were if they were of a younger age, if they had a worse neurological scale, if they had a lower systolic blood pressure. Patients with antiepileptic drugs, they had an increased chance of a poor outcome, vasospasm, neurological deterioration, cerebral infarction, elevated temperature during hospitalization, more hospital complications, and worse outcomes. Possibly, I think, they were more sicker, and that's why, you tend to give the antiepileptics rather than the other way. And what about so coming to EEG monitoring? So what is the prognostic significance of continuous EEG monitoring? So they had, this again comes from the Columbia group, they had 116 patients. They had monitored for about 4 days. And usually they were poor grades of arachnoid hemorrhages. They correlated the EEG changes with the modified Rankin score at 3 months. Poor outcome was MRS of 4 to 6. And so after controlling for all the other risk factors, if there was absence of sleep architecture on the EEG, if there was presence of pleds, they had increased chance of poor outcome. And the poor outcome was seen in all patients if they had no reactivity, if they had G pleds, bilateral pleds, and in 90% of patients with non-convulsive status. So at least it may tell you, how your patients are going to do. What about patients who underwent multimodal detection? So multimodal monitoring was initiated in patients with coma who are not going to regain consciousness within 48 hours and who are going to survive for more than 48 hours. So all the monitors, the Lycox, the Hemadex, the depth electrode, the jugular venous, that is the O2 sats and the microdialysis catheter was installed. So what did they do is all the patients got prophylactic Dilantin for a week. If the patient had a clinical seizure or a scalp seizure, they gave levetiracetam. And if they had status, midazolam was used. And they saw periodic, they looked into what the EEG pattern was. And they continued the AED if they had bleds, but they did not want to eliminate bleds completely. They had 48 patients who underwent multimodal monitoring. And what did they look for? They looked for if the patient had an ictus, interictal continuum, or if it was non-ictal even. Scalp seizures were seen in 8% and intracortical seizures were seen in 38%. Now, what impact did intracortical seizures have? Definitely, it increased your heart rate, your blood pressure, your respiratory rate, your CPP, and your ICPs went up. But there was no increase in cerebral brain metabolism. That is, your jugular venous O2 sats did not drop a whole lot. Neither there was an increase in cerebral blood flow.
What do you mean exactly by intracortical seizures?
So pardon is that is they inserted depth electrode. So within the depth, you are recording the seizure activity, but it's not. It may be seen on the scalp, may not be seen on the scalp. So they looked into depth seizures. So those whether what happens to the brain metabolism during that time. So definitely, the hemodynamics have gone up, but it did not increase the brain metabolism. That is, the oxygen demand did not go up. So the hypothesis was hey, if your heart rate goes up, your minute ventilation goes up. But if you're compromising your metabolic demand has reached, then definitely there's no further damage. But if your brain is not able to increase your blood flow, definitely your tissue is going to become infected. So so they were just trying to see, hey, is this going to cause more infections or no? So that's the whole idea, behind this, is your tissue being at risk. So there was no increased risk of brain metabolism, at least. Only there was a transient drop, but this is the hypothesis of it. You may have increase in your parameters, but the outcome. Well, again, it's a small pilot data, right? Now, what did they analyze? They analyzed the EEG. So they looked into, what the thing was. If there was attenuation in background, 70% of them had poor outcome. If they did not have attenuation of background, but they had only depth seizures, 50% poor outcome. But if they had surface seizures, 25% had poor outcome. If they had only no or mild attenuation of the background, only 0% had poor outcome. So, at least it just tells you, your outcome, what is going to happen, Again, this is just last conclusion, so when do you see, then a shunt-dependent hydrocephalus? It can be seen in 8 to 50%. Again, the various predictors are age, and their admission glucose is higher if they are on mechanical ventilation. If they have more hydrocephalus, the bicardiac index is at least 0.2. If they have posterior circulation aneurysms, if they had giant aneurysm, or if they had large amount of blood or blood within the fourth ventricle, if they have vasospasm, and they have nosocomial meningitis. And so what about the data with IV intraventricular fibrinolysis on shunt dependency? Again, this was again 88 patients who had underwent they had an EVD, and they went TPA was administered within the thing to see if it worsens your shunt dependency. 14 patients of them required intraventricular fibrinolysis. There was no significant difference in the shunt dependency in patients who got it and who did not get it. Well, the predictors of shunt dependency was if they had large amount of IVH, which is scored by the GRAP score, and sepsis, so that is any kind of infection. So, inserting all these things would not change your things. And poor outcome, that is if you postpone your initial treatment, that is, your coiling or your clipping, these people are going to have poor outcome. At 2 months, your modified Rankin score of more than 3. So that is over here. They compare 2 days versus 10 days. Patients who are treated more than 10 days did the worse when compared to patients who got treated between 5 to 10 days when compared to 3 to 4 days. So that's why earlier treatment is better in these patients. If they had substance abuse on board, then these people are going likely to have poor outcome. If they had DWI lesions on the initial CAT scan or the MRI, that is during the time of presentation, people have done MRI studies. So these patients have an increased risk of death, disability, delayed cerebral ischemia. So, the process of ischemia is happening at the time of subarachnoid hemorrhage itself. So that's why, when you're seeing these markers, these patients are going to do poorly. And if they had CT infarction or if they were elderly, these patients are likely to have poor outcome. What about the long-term outcomes? So the aSAH data, definitely the long-term mortality, once you survive, subarachnoid hemorrhage, is a bit high. It's about 1.5. The Swedish data, which had around 11,000 patients, it was around 1.6. The follow-up period was about 6.8 years. Residual deficits, that is independence of MRS of 0 to 3, was seen in 30 to 50%. The clinical condition at admission was the best predictor of outcome. So how they come in is the way how they go. Cognitive dysfunction, memory impairment was seen in 60%. Executive function was impaired in 70%, and language was impaired in 75%. Coma, 1 in 5 comatose patients on admission, they can recover without any cognitive or physical deficits. So that's good, you know. I mean, like mood disturbances can be seen in 50%. Deficits in smell and hearing is seen in about 30%. Among those who survive long, the quality of life can continue to improve between 5 to 12.5 years. So that's why, you know, there's a delayed improvement, you know, in these patients. Many of the times when you start thinking, you know, do you need to score them once the patients are resuscitated, because that gives you a better clinical grade, right? Because hydrocephalus is a thing, you know, which can skew up the entire picture. Once the EVD is done, the patient is more awake and, you know, doing better. So that's it. I think we are on time.
Just one quick question. You said the hypertension increases the chances of rebleeding,
oh, yes.
right?
Oh, yeah.
So, but also you want to induce hypertension to prevent
that is
vasospasm, etc. And you want
that is after securing, right? So this is before securing.
But you mentioned one of the slides in unsecured, you also hypertensive did better. In unsecured.
Yeah, but those were those olden days, right? I mean, like, yeah, correct. But then, like in those unsecured, they raised it to 160. Whereas in secure, they raised it to 240.
Ah, okay.
Okay, so that was the data. Yeah.
Some of that safety data from unsecured aneurysms comes from Jefferson, where they looked at the database of patients that had multiple aneurysms. So they fixed the primary aneurysms, they developed vasospasm, and then they induced hypertension. So the unruptured aneurysms did not rupture as a result.
Okay.
So I found this really interesting because I think I had a completely different idea about what causes vasospasm. You know,
I'm not going into pathology.
So my thought was always that blood is irritating, the vessels are spasm, and so there's not much you can do about it except maybe a calcium channel blocker. But what it sounds like to me is it's all in response to hypovolemia. And so if you pump the volume up and keep the cardiac output up, and you don't require hypertension necessarily, but volume's the big difference. And so what I wonder is if there's a blood-induced renal mechanism that causes diuresis or something, and that's why they get hypovolemic in 2 or 3 days, and you get this late vasospasm.
But like, you know, you're having ischemic things at the time of subarachnoid hemorrhage.
Right.
So, you know, like, there's a whole different theory, you know, cortical spreading depression, microcirculatory things. There's a whole different thing. I think it's way too complex, you know. It's good.
But it's not just blood is irritating.
No. It's beyond
that. It's a nice way to explain to the patients.
No, yeah. It's beyond my level of thinking. Okay, anything else?
Yes. You mentioned, you know, lumbar drainage.
Yeah.
Well, that's a long way away from where the blood is coming. I mean, why wouldn't it be more logical to try to drain the blood from the cisterna magna?
No, so they did that also. Even the cisternal things have been done. Again, a lot of controversies, you know, with that. So cisternal, these patients had an EVD plus a lumbar drain. So they had both. Okay, yeah. So they have that. That is data on cisternal thing also. I did not go into more of those procedural because I think that will be too much.
So it didn't change the long-term outcome, but did the lumbar drain decrease the chance, the length of hospital stay? That would be one thing, because otherwise.
No, I mean, in fact, you are going to have your catheter, right? So catheter infections have been seen. Different groups have seen, you know, catheter infections is a lot. Yeah, no. It doesn't increase. We have seen that also.
It doesn't increase the length of stay?
No.
You're not getting
they're going to stay in the ICU because they'll not monitor and step down. So you're going to waste money.
And the other question I had was, you know, early on you're giving them antiprophylactic agents, and then later on you're giving them heparin. So where is the changeover?
Well, we like to play with pharmacology, right? That's what we do.
Yeah, just to put this in historical perspective, I think the biggest change I've seen in the management of aneurysms is early intervention. 35 years ago, what we knew was that people who had surgery because they went in blood, clipping, within 2 weeks of their subarachnoid hemorrhage did worse. And so what we did when I was a resident was we would admit these people and put them on epsilon aminobutyric acid and volume expansion. It went 2 weeks, and then they'd be operated on. And then the Japanese became involved in this necessary surgical intervention. And because of improved surgical technique, they were able to eliminate the bad outcome of these people had from early intervention. You remember that, Dr. Lucy?
Yes, the times vary. Now, early on, we wanted to clip very early. And I remember when Steve Flanagan first came here as our neurosurgeon, he started out that he would do them on an emergency basis. Now, we'd work them up, but he'd do them on an emergency basis. And then he decided that he was losing too much by not having his OR group that would come in at night. So he stopped doing them at night, and then I remember a patient that came in one night, we worked him up, found an aneurysm, and he had decided at that time he would not operate at night. He'd operate the next day, and the man bled again and died that night.
And I think the basis for all that was a big study published by Dr. Science.
Yeah.
And actually, just recently, I found that I have a copy of that, and I put it up here to put in the library of Dr. Saz's original study.
Yeah, you know, they published a book, and some of these are repetition, but done differently than what they did. One of the things that they tried was lowering blood pressure, but they did not detect that there was any benefit from doing that. Now, real quickly, Dr. Saz, University of Iowa in 1960 was head of a multi-city study of primary subarachnoid hemorrhage, the vast majority of which were ruptured aneurysms. And that study went on for a number of years. There were, I think, 100 more publications, a couple of books. I've got one of the books downstairs. That was the first study of primary subarachnoid hemorrhage and ruptured intracranial aneurysm. And I don't want to prolong this, but one thing that struck me was the data you gave on multiple aneurysms. I may have not understood it, but it looked like there's a lot less than that cooperative study. In that cooperative study, on the basis of arteriograms, 1 out of 5 had another aneurysm besides the bleeding aneurysm, and the autopsy data was 1 out of 4 had more than one aneurysm. And that was, I don't forget how many patients.
Plus, if someone has an aneurysm, they can subsequently develop another aneurysm too. So we have to follow these people.
I've not followed that, but the old data, I used to really keep up with that, is these people have a difference in the arterial wall, particularly at the junctions. They're born with weakness in this wall. Their aneurysm's not congenital, but the defect in the vessel wall is, and these people are predisposed. Is that not still thought to be true?
Yeah, that's why if you have one aneurysm, you are prone for having another one. You know?
And you're going to have your arterial structure, the wall, is not going to be normal. It's not going to have the continuity of structure that most people have.
Archana, has anybody segregated out amyloid angiopathy bleeds from, say, standard MCA proximal aneurysm type bleeds?
I think angiopathy, there was one paper I read, microbleed, seeing nothing. There was a higher incidence of microbleed. It's in the Green Journal, but I don't know more details. Yes, they have looked into that.
Patients with amyloid angiopathy can present with pure subarachnoid hemorrhage. That is underreported sometimes.
One other thing.
Usually, superficial, and it's not the typical external.
Yeah, it's very cortical subarachnoid.
Yeah.
I don't think you mentioned early Stanlow syndrome as a.
Yeah, those are all.
But I don't think you mentioned polycystic kidney.
Oh, I wrote.
Oh, you did?
Yeah.
Okay.
I did not want to.
Also, coarctation of the aorta.
Yeah. Mm-hmm.
And is there a dietary risk factor? I mean, it seems there's more of it in Japan. Eating fish and maybe salted fish.
I don't know. Did I look into diet? No.
Sushi is a risk factor.
I don't know. Yes.
Last one, Dr.
How do you follow these patients who have one aneurysm? Certainly you don't do angiograms on them anymore.
I think every yearly you need something, right? CTA or an SETA. CTA is good nowadays, right? You know, DSA.
Post-endovascular foiling, they always get follow-ups, maybe 6 months,
Follow.
maybe a year.
Yeah.
Craniotomy, typically not so much.
Yeah.
Unless you have multiple aneurysms.
Yeah.
But I think that's institution dependent.
And how, yeah. I think angiogram is good, yeah.
Thank you, Dr. Hinduja. That was terrific.
So,
Before people disperse, I want to remind you, Dr. Naval is our guest today from Hopkins Neurocritical Care, and he's going to be talking at noon, and it will either be additional things on subarachnoid hemorrhage, or it may be a different topic.
no, it's okay. They can at least they heard the basics, now they can learn.
No, this is pretty detailed. I'll go over something else.
Okay.
Oh, I did not know that, you know.
We didn't realize it was going to overlap completely.
Good morning. What y'all do with your studies? I've done our faculty meeting over in radio.
He's going to study my autopsy.
So you have a chance to talk with them?
You got one. Okay.
Oh, yeah. It's been a very good hour.
Okay, I'm going to start the loading.
This is an almost no significant. If you have
So why don't we do it first? I'm serious. We'll incorporate. Oh, yeah.
The other side just stay with the new one. Did you notice the day don't worry about it.
I'll change the light. Let me see from here. I'll check it out. Is it in the
People, most people don't even look at it. I picked more than one, so I looked at it. It says 2012, that's 2013.
Well, it's probably, they use the same thing.
Yeah, it's in a
I
center.
don't know. I mean, I was quite fast, but I could not.
Well, in
I learned a lot, but it's
it didn't really make us any different.
Out of interpreting all of that, putting all together, because even when you add all up, evidence, and you're like, okay, what do you get out of this?
It's not worth it.
But
Did you find it?
You know what are big things, you know? Like, okay, are you going to step out of this? No. It's your physiology. It's not other learning. Okay. You can talk about Subarachnoid. They don't know anything.
They know a lot now.
No, they can talk.
Yeah, it's just a very how to digest I know, I wouldn't even worry. It's at the very top of the
This is good, this is good.
I don't think it's worth it.
It's okay, so thanks a lot.
I'll see you later.
Yeah, see you later.
Okay, thanks. Thanks, Dr. Lucy.
Thank you.
What's up, Aline Harlopian? Okay. Thanks a lot, Dr. Lucy.
Oh, thank you. Gosh. You must have a phenomenal memory to remember.
No, it was not easy. I spent a lot